Good evening, ladies and gentlemen. Thank you for inviting me to talk on lymphoma cases in Oncology Summit. So, in next 10 minutes, you are all experts here. I have nothing new to tell you as lymphoma are as old as hills. But what is challenges in 2022 in diffuse large B-cell lymphoma? The big challenge is aggressive high-grade B-cell lymphoma, double hit or triple hit. So we'll focus on rules of oncology to make a diagnostic and therapeutic dilemma in this contents. So this is my case, 50-year lady who was referred to Thamam Hospital actually 3 years ago with 4 month history of typical B symptom and with increasing weakness and unintentional weight loss and poor appetite. The symptoms were worsening, and finally she went to some other hospital. There they found pancytopenia, and she was referred to our hospital by aplastic anemia. So this was the first slide when the patient came to our hospital. You can appreciate hemoglobin is 4.7 and the platelet count is 40,000 and WBC count is low, ANC is 1500. Other things you can see, creatinine liver function test is normal, LDH is high, is about 700. So now the question is, when there is cytopenia, what it comes in our mind? First thing comes is aplastic anemia, and this age maybe there is MDS, PNH, and myeloproliferative neoplasm. So which of the following would be the most useful in achieving diagnosis in this patient? So three things we will do. First, we do peripheral phlegm, some hemolytic workup, and the bone marrow. Let's see what came. You can see in imaging, we couldn't find anything except hepatosplenomegaly. Film shows fine, platelets are adequate, mild leukopenia is there. Immunological and infective screening is negative, and nutrients are normal, and kappa lambdas are normal, and interestingly, bone marrow is completely normal. Now, which of the following would be the most useful achieving diagnosis in this patient? The rest is left CT scan to see if anything is hidden. They found that there is hepatosplenomegaly. There is some lytic lesion as well in the bone. So plasma cell maybe, and left breast mass also shows two small nodes as well. So breast cancer as well. Well, let's see. So which of the following would be the most useful achieving diagnosis in this patient right now? So two things are there. We should do mammogram. We should do myeloma workup. So mammogram was done that revealed multiple bilateral hypodense mass. This is category 0. Then they found ultrasound. They found bilateral hyperdense mass like lesion. But what we should this mass? No meet, no treat. Do biopsy. Biopsy was done, and that revealed you can say fibroadenoma. And meanwhile, myeloma workup found there is no M protein and 24-hour urine collection was also normal. So what to do? We are at same place. Which of the following then most useful? Then again, I appreciate Dr. Arif Alam. He says, skip bone marrow. Is there is chances, repeat the bone marrow. So what was done? Repeat bone marrow was done. The bone marrow was compatible with a diffuse large B-cell lymphoma, very high Ki-67 is 80%. It was BCL2 is also positive, CD20 positive. So now we have now, based on, the goal of NHL is first is make is ABC. A means accurate diagnosis. Now we have accurate diagnosis, diffuse large B-cell lymphoma. B is before beginning treatment, review the labs again. Let's review. So if we review the labs, we found the patient has fever, splenomegaly, and cytopenia, and ferritin was 3,000. What is missing here? Is it shower of cytokines? Yes, it's shower of cytokines. Patient has fever, splenomegaly, cytopenia. Patient have high triglyceride. Patient have low fibrinogen and very high ferritin. So what is this? Patient has HLH. HLH secondary to malignancy means patient has DLBL with HLH. Now we know cytokine cause fever, pancytopenia. So this is the typical found in this patient. So where we stent, the patient has actually stage 4BS for spleen, stage 4BS unfavorable. Now we have this patient. So what we to do? Next step is the treatment. So if you go by NCCN guideline, the front line in diffuse large B-cell lymphoma, the first line treatment is R-CHOP chemotherapy. And you can give dose adjusted or epoch in some cases, which have aggressive disease. And you can consider also IT or high dose methotrexate based on the high risk of CNS involvement. So where we should do, patient has HLH, check the HLH guideline. There is, we have to go HLH 04 guideline as well. So treatment includes targeting the underlying disorder, which is DLBL, and also control the immune dysregulation. The key pillar in HLH is what? You can see here, dexamethasone, etoposide. So now, this is HLH 2004 protocol. So we have to treat DLBL with HLH. Now, what is your thought? Think over this. 50-year female, diagnosed, high grade, stage 4 VS, diffuse large B-cell lymphoma with HLH, with high IPI score. So what you will do? You have choice: standard R-CHOP 21, R-CHOP 14, dose registered R-epoch, or if you are, this was case in 2019, suppose in 2022, what you will do? You will go to Pola R-CHIP, or you will treat first HLH2 protocol or clinical trial. So these things are actually, I think, reasonable. So what we should do to kill two birds with one gun, that is possible? Yes, this is possible. If you use dose-adjusted R-epoch protocol, you will use also, here etoposide, dexamethasone as well. So why not we use this one? So we started this patient, and she tolerated first cycle and second cycle also in January 29. She has very good improvement. And unfortunately, 17 January 29, she landed it with us, vomiting, fatigue, neutropenia, and she has subdural hemorrhage. It was a massive hemorrhage, and she underwent ventilator, and she was intubated. She was in ICU. Now the patient is in ICU, aggressive diffuse large B-cell lymphoma, HLH is there. What we should do? We should sit tightly, not do anything. I don't think so. This is a good idea. What to do? The good thing is we have to still, we cannot go dose stage R-epoch this time, and we cannot switch other chemotherapy. Best thing is we can start HLH protocol with rituximab treatment, which is a safe during patient on vent. So we did this one. She completed induction chemotherapy while patient was in ICU. And now the thing is what we should do. Two cycle chemotherapy, then induction for HLH protocol, then what we should do. Now we restart dose state R-epoch and followed by HLH protocol maintenance. This is how we did in this patient. So now you can say this is the whole journey of the patient. Patient came with a severe pancytopenia. We started dose R-epoch. Then patient went in vent because of the chemotherapy side effect. Then patient has maintenance phase HLH protocol. And then, patient has given again dose R-epoch chemotherapy. Now the patient is in the CR. So after 1 year, patient landed it again with a complaint of abdominal pain, and we found now the lymph nodes over there in the abdomen. The biopsy was done, that it was compatible with the diffuse large B-cell lymphoma. There is no parameter of HLH. Now what we should do, I know the standard, and also the standard salvage chemotherapy, patient should go for autologous transplant. The chemotherapy was given RDAP, and after 2 cycles, the patient is CR. She completed 4 cycles, but we don't have access of autologous transplant that time as well. And the patient was just given chemotherapy, and she is poorly. She couldn't go for autologous transplant. So over the 1 year, she is doing great. Now this is the whole journey. The patient has initially diffuse large B-cell lymphoma with bone marrow involvement with HLH. So this is the first diagnosis. We started dose adjusted R-epoch 2 cycles. Patient went in ventilator. During ventilator, we started induction phase to HLH 94 protocol. Once patient is stable, we restarted again dose adjusted R-epoch for 4 more cycles, 6 cycles. And then she continued maintenance phase of HLH protocol. She was good for 1 year. Then again, disease came back. The patient again received RDAP protocol. So this is our journey, you can say, and think over this, and we will discuss some question raised in this patient. So what we see the roles of oncology are reminded here. A, B, C. A means accurate diagnosis. Think wide angle, not miss the diagnosis. You have noticed we have done 2 times bone marrow to eventually we found the diagnosis. It's very difficult. And before beginning treatment, view the labs. As we found, HLH was behind the diffuse large B-cell lymphoma. And C is considered a potentially curable option with the least long-term toxicity to kill 2 birds with 1 stone, which we did here. And rule number one, rule number 3 is never forget rule number 1, which is what? No meat, no treat. You have seen we have done 4 times biopsy, 2 biopsy from the bone marrow, 2 biopsy from tissue, breast, and lymph node, and finally we reach a diagnosis. So this is again similar with just one slide. One elderly lady, poor performance, multiple comorbidity, aggressive diffuse large B-cell lymphoma, invading the pancreas, stomach, small intestine, adrenal gland. She has very high chances of 50% CNS involvement. So now this is more or less same like, as I mentioned, aggressive diffuse large B-cell lymphoma. What we should do, again, in this patient, we just give mini choke with IT chemotherapy, and after 6 cycle, she's in complete remission. So now over the 3 years, she's doing following to us. So this is first CT, then complete remission. So the idea is to show about the NCC, and you can say how we define aggressive double A, triple A. That anything is there with the mic or BCL2 and BCL6. So if 2 is there, we call it double. If 3 is there, triple. And they are very poor prognostic, having LDH, bone marrow, and CNS involvement, high IPS score. And here you can see the guideline. If the patient RCHOP is suboptimal, mini RCHOP may be considered for frail patient like we did in our patient, and dose adjusted epoch R should be given in aggressive young patient. So we give also this patient. So now my questions raised during this both cases: what is the optimal therapy for double or triple hit lymphoma in 2022? Should it still be dose adjusted or echo chemotherapy or POLA-based chemotherapy? And what about the CNS prophylaxis? Should be given double and triple? It should be given IT or high dose methotrexate. If high dose methotrexate should be given in between the cycle or end of therapy. If high dose methotrexate is given at the end of the induction, then how many cycles? So these are the questions we will discuss with the experts during discussion, and especially as I mentioned, diagnosing therapeutic dilemma in the high grade diffuse large B-cell lymphoma. Thank you very much.